Module 19, the female athlete triad. What are the components of the female athlete triad? Well, the first of which is going to be disordered eating, as we discussed in Module 18. So this is really all about energy availability. So low energy intake. That would then lead to amenorrhea. Of course, this is a menstrual dysfunction, which then, because of the menstrual dysfunction, that ends up leading to osteoporosis and reducing overall bone strength. What is amenorrhea? Well, amenorrhea is simply the cessation of the menstrual cycle. There are different types. There's primary amenorrhea, which is simply delayed menarche, and so if a menstrual cycle has not begun before the age of 16 years of age, then that would be considered primary amenorrhea. Secondary amenorrhea happens after menstruation has started at any point in the female's life, and that's where we have an absence of at least 3 to 6 consecutive cycles. So both of these, primary amenorrhea and secondary amenorrhea, are both more prevalent in the female athlete. What is the prevalence of amenorrhea in athletes? Well, this is kind of all over the place, as we have seen in the literature with other topics in athletes, and it's estimated anywhere between 1 to 44%. So that's all over the place, all over the board. As far as gymnasts are concerned, in some studies, about 100% of the individuals studied were amenorrheic. Lightweight rowing, 67% of those folks. Distance runners, 65% of distance runners. Ballet dancers, 52%. Swimming, 31% prevalence. And team sports, about 17%. So this obviously, no matter what kind of sport that you look at, is a problem in the female athlete and significant to their long-term health, as we'll discuss. Why are female athletes susceptible to menstrual dysfunctions? Well, number one on the list here is that they may have a history of weight fluctuations, which can affect the menstrual cycle and how regular a menstrual cycle is. The second one here, which is the more likely of all of these, is that they may put themselves in a state where they have inadequate energy intake. So disordered eating may lead to this, or something odd about what they're doing as far as their diet is concerned. And so this is the primary cause of amenorrhea in athletes, and it usually is associated with a reduction of intake and total kilocalories by greater than 30%. This causes an energy drain, so there's a lack of energy availability, which also results in nutrient deficiencies and subsequently will lower body fat levels. Now, rigorous training can induce energy deficits. However, exercise alone is not the cause of amenorrhea. There has to be that energy deficit present through diet in order to make this happen. Societal pressures may also result in menstrual dysfunctions as well because of the competitive nature in sport. Is it not true that amenorrhea is just part of being an athlete? This is a huge misconception by athletes and coaches and trainers alike. So we need to make sure that we get good information to these folks. So in reality, there are severe consequences to amenorrhea. This is not something to be taken lightly. It will impair bone health and lead to osteoporosis, which is, of course, an inadequate formation of bone. We get premature bone loss, which spells low bone mineral density. There's also an increased risk of fractures, especially stress fractures, from a buildup of microdamage that is not repaired by bone remodeling. Symptoms can include local bony tenderness with a history of bone pain. The athlete is 2 to 4 times at increased risk compared with a eumenorrheic female for these issues. Oral contraceptives, however, may actually reduce some of this risk because you're replacing some of the estrogen that may be lost with being eumenorrheic from the resulting energy deficit. So this may be irreversible, even with the resumption of menses and estrogen replacement or even calcium supplementation. So there may be irreparable harm that is done to the female athlete as a result of not menstruating on a regular basis. Why are menstrual patterns important then? Well, if the athlete has always been eumenorrheic, then their vertebral bone mineral density is likely to be higher even after correcting for body mass compared with amenorrheics. So that's an important consideration. Amenorrhea, we know, will lead to a low bone mineral density. This uncouples the whole bone turnover process that we'll talk about. It may affect the non-weight-bearing sites more, such as the lumbar spine. It also may lead to bone loss, which will still occur even if activity level is high, and this can result in irreversible bone loss. So we're talking about some permanent damage that can happen here as a result of not having a regular menstrual cycle. If eumenorrhea resumes, the athlete, again, may not fully recover. They may not get that bone that they've lost back again. So researchers have looked at this and they're reporting lower bone mineral density compared with other athletes. So athletes who have become amenorrheic may actually never recover, according to at least this particular study. Reproductive function and bone turnover are both disrupted in exercising women when energy availability is going to drop below about 30 kilocalories per kilogram of fat-free mass. That seems to be the magic number for caloric intake as far as causing these menstrual dysfunctions and low bone mineral density. Other problems can manifest, such as a depressed immune system, reproductive problems, and an increase in cardiovascular disease risk factors. What's the mechanism for reduced bone mineral density with amenorrhea? Well, amenorrhea is going to lead to low levels of estrogen and progesterone. So these are hormones that are important in regulating the menstrual cycle. This leads to a decreased rate of bone turnover. This has been documented in athletes quite nicely. However, amenorrheic athletes on estrogen therapy were not very responsive. So perhaps this is not the mechanism. We're not quite sure. At least in these studies that looked at replacing estrogen in the amenorrheic athlete with some hormone levels. They still ended up with decreases in bone turnover, and it may not be due to the hormones. So in runners, a BMI of about less than 17.5 was actually associated with the lowest formation of bone. So maybe undernutrition could be the culprit in this particular population. Nutritional factors independent of estrogen may be the most important factor in determining bone mineral density in athletes, and perhaps not just the estrogen and progesterone levels. What's important to remember about the skeleton for the female athlete triad? Well, the first of which we want to understand is that the skeleton is designed to withstand mechanical loading of weight-bearing forces. We also want to understand that there are two divisions of the skeletal system. We have the axial system, which are the trunk bones, and the appendicular system, which are the long bones of limbs. We also have some major constituents of bone. We have the cortical bone, which is also known as compact bone. That's the outer bone. That's about 80% of the skeleton. Then there's trabecular or cancellous bone. This is the inner bone or the spongy bone. That's about 20% of the skeleton and is definitely more metabolically active than cortical bone. It also has a faster turnover, and it's more sensitive to hormonal changes than cortical bone. So this is a picture just showing you the different areas of bone. So here on the outside, we've got the cortical bone, and then the inner part here, this is the trabecular bone. That's the spongy bone. So those are the two areas that are of concern here for us when we're talking about osteoporosis, as we'll see in just a few minutes. What is bone remodeling? Well, bone remodeling is simply the continual resorption, which means that you're taking apart bone, and formation of bone. So this is constantly happening. Every 4 to 6 months, we actually replace the entire skeleton with new cells, with new mineral. And that's because of this whole bone remodeling that continually goes on. It does come in stages. There's the quiescence stage, there's the activation stage, the resorption stage, which again is the breaking apart of bone, and there's the reversal of that process, and then bone formation. Cells that are involved in bone remodeling, very simply, include two major ones of concern here. Number one are the osteoblasts. These are the cells that build bone. They are going to help produce nice mineralized bone, increase bone mineral density. We do need to have collagen synthesized for mineralization as well. Collagen is a protein that needs vitamin C in order to be formed. And so then collagen is used to then lay mineral on top of the collagen. We also have osteoclasts, which are the cells that basically degrade bone mineral. They're going to have podosomes that are going to cover the area and extrude acid and lysosomes to the area, which cause the release of the calcium and phosphorus and magnesium that are located in bone, and so they are going to serve to decrease bone mineral density and destroy the matrix for which calcium and all the other minerals are deposited upon in bone. So the main concern here is that bone resorption, if that's greater than formation, that's going to equal bone loss, which then leads to osteoporosis and an increased risk for fracture. So bone remodeling, as depicted here, we've got in the top half of this activation. So we would activate the osteoblasts to basically move out of the way and allow the osteoclast to come in and release that acid and extrude the minerals. And of course then once the osteoclasts have done their job, they've demineralized bone, then we can reverse that whole process, and so then we have osteoblasts that are then spread out again and come in and replace bone mineral and form bone once again, so that we continually have this bone remodeling going on to replace cells that need replacing and ensure that the skeleton retains its strength that it's designed to withstand. What's the difference between osteopenia and osteoporosis? Well, this is very important to understand this difference. Osteoporosis is defined as a bone mineral density that is 2 or more standard deviations below the young adult mean. So in order for someone to be considered osteoporotic, the standard bell curve that you often see in statistics, basically what we're saying is that their bone mineral density is way down on the left-hand side of that graph. So they're 2.5 standard deviations below the young adult mean. Now there are different types of osteoporosis that we should be familiar with here. Type 1 is basically the kind that we think of with osteoporosis. And it does typically affect females more so than males. It's actually quite rare in males. And during menopause, around 50 years of age or so, it does seem to manifest more so. It affects trabecular bone, so that inner spongy bone is more affected by type 1 osteoporosis. And it tends to affect the lumbar vertebrae more so than any other area. However, other areas can be affected as well. And the etiology behind this is that there's a loss of estrogen or androgens. Now, there is type 2 osteoporosis that affects both female and males, and usually beyond the age of 65 or so, so into the senior years. And it does affect trabecular and cortical bone in this type of osteoporosis. The hips, vertebrae, and any other bones in the skeleton for that matter can be affected by this kind of osteoporosis. It is typically associated with just a natural process of aging, and we don't really have a good understanding of why that kind of osteoporosis occurs. So here are some pictures showing the differences in bone mineral density. So in this to upper diagram here, we have bone mineral density. We have bone that there's a cross section here. You can see that it has a lot of cross linking, has a lot of mineral deposited, compared with the panel B here, which shows you that there are a lot of areas that really don't have any support whatsoever from bone mineral density, and it's missing collagen, so there's a lack of that bone matrix present to formalize the mineral on bone. So obviously this bone would be much weaker. This picture here shows you a little bit more of an exploded view or magnified view of it, and you can see that in the bone on the left there are just wonderful connections here in bone that provide bone with all the nice strength that it has. But in osteoporosis, you're missing a lot of those links, and you have much larger spaces, and you're trying to spread out the forces that are placed on bone over these smaller areas here, and that leads to a decrease in overall strength. This last diagram here is just showing you what happens in the aging process with osteoporosis. And osteoporosis is associated with what's called a dowager's hump. And that's because, again, a loss of this bone mineral density then causes a weakness of bone, and so then the head can't quite be supported as well. So what are the risks for developing osteoporosis? Well, there are several factors here involved. The first of which is peak bone mass. So what is the maximum amount of bone mineral density that somebody can achieve? And this happens to occur during adolescence and early adulthood up to about the age of about 30 or so. So body mass can be used to predict bone mass. We've known that for decades. There was a lot of work actually in the 1940s looking at the structure of bone and looking at the sizes of bone, and then relating that back to what the person should weigh as far as body mass is concerned. We do need to account for size differences, so that's important. About 60 to 80% of the variability in peak bone mass is determined genetically. We know that bone mineral density is strongly linked to bone strength as well as resistance to fracture. So this is a very, very important point here to remember. Now this diagram down here on the bottom right hand corner of your screen shows bone mineral density on the y-axis, and on the x-axis we have age in years. So here's the age of 30. This is where the peak bone mineral density tends to peak out at, so to speak, and it doesn't increase any more so after that point. So we spend our adolescence and our 20s trying to achieve peak bone mineral density so that we have enough as far as a reserve is concerned, so that when we age and we lose bone mineral density, which is inevitable, we stay out of this fracture risk zone. So we want to be up higher on this list so that we don't run the risk of fracture and being osteoporotic. So other factors for developing osteoporosis: family history. If there's a family history there, then that person's more likely to have higher risk for osteoporosis. The female gender, more at risk for osteoporosis. So other risks for developing osteoporosis include race. So Caucasians have the highest risk for osteoporosis, Asians have a moderate risk, and African Americans have the lowest risk for osteoporosis. Having a slight build or being underweight or underfat also increases the risk. Having estrogen depletion through hypogonadism, through menopause, or an oophorectomy, etc. That is anything that's going to lower basically estrogen levels is going to increase the risk. Age, especially after the age of 60, increases the risk. Being sedentary, and that couch potato, that increases the risk. Prolonged use of medications, diseases that affect calcium and bone metabolism, cigarette smoke increases the risk. Excessive caffeine or alcohol consumption increases the risk. Excessive fiber consumption can actually increase the risk for osteoporosis. And of course, an inadequate intake of calcium or vitamin D intake all increase the risk for osteoporosis. So what's osteopenia? Well, osteopenia is essentially the same as osteoporosis. It is a low bone mineral density. However, the way that we look at this is using the statistical bell curve, and that is looking at bone mineral density, and if that's 1 to 2.5 standard deviations below the young adult mean, then that person is considered to be osteopenic. So it's very common in female athletes to be osteopenic and not necessarily osteoporotic. Now, why should we be concerned about that? Well, let's take a look at the diagram down here in the bottom right-hand corner. We have trabecular bone mineral density on the y-axis, and we have age in years on the x-axis. And we have two individuals, somebody with a high peak bone mass and somebody with a low peak bone mass or bone mineral density. The dashed line represents the fracture threshold. So if the person who never ends up with the female athlete triad, they develop their peak bone mass quite high, and as they age, you'll see even out to the age of 80, they never enter that fracture risk zone. Whereas the person who ends up with the female athlete triad, they may not feel any different. They may be considered osteopenic. They have this low bone mineral density. However, as they age, because they're starting out with less, then they do enter that fracture threshold, which means that then they could be setting themselves up for breaking bone. And the sad statistics regarding this, especially in the elderly, is that once a fracture occurs, and it may be debilitating enough that within about a year, these folks are passing away, unfortunately. So this is something that we want to be concerned with. We don't want to set up these young ladies for disaster, osteoporosis, and fractures later on in life. What role does exercise play in bone mineral density? Well, exercise is critical to maintaining the architecture and mass of the skeleton. There's no question about that. Athletes do tend to have higher bone mineral density levels compared with sedentary cohorts, so that's the good news. Female athletes in particular can benefit greatly from weight training, and the kind of weight training we're talking about here is certainly not bodybuilding unless they choose to, but 2 to 3 times a week doing a general body routine will get all of the nice benefit from having a higher bone mineral density associated with exercise. Now, when we look at the amenorrheic athlete, we know that the weight-bearing bones may be partially protected by mechanical loading. However, the non-weight-bearing bones may not, and that's the scary part about this. Exercise effects, one thing to realize, are very site-specific. So the lumbar spine seems to be affected greatly by exercise, as well as the femur trochanter area. So that's important to understand that depending upon the exercise that's done, that can be very, very site-specific as far as return on bone mineral density. Both running and weight training are effective for stimulation of bone mineral density, so that's good news there. We have been shown in the literature that young premenopausal and postmenopausal women can benefit from doing weight-bearing activities and doing resistant type of exercise. So that is good news in combating osteoporosis. So there is some evidence to suggest that bone accrual is greater if high-impact activities are begun before puberty. So that's something kind of interesting to look at as well. What is the mechanism by which exercise stimulates bone mineral density? Well, there are several mechanisms out there, the first of which is called the mechanical loading principle. And so with the mechanical loading principle, basically what we're saying is that forces are induced by the contracting muscles. So there's pull from the muscles on bone, which then will stimulate bone to build bone. So the osteoblasts are mobilized. This typically affects bone mineral density in non-weight-bearing bones, like swimmers and cyclists, who are performing non-weight-bearing types of activities. We also have gravitational induced strain, so this typically affects bone mineral density in the weight-bearing bones, like the calcaneus area. It requires both a pull and gravitational force to affect the bone mineral density, so there's a higher threshold to get the osteoblast to mobilize with these kinds of forces, the gravitational induced strain. So in gymnasts, the femoral neck BMD is actually increased because of these kinds of forces. We also have something called cellular accommodation, which in the literature you'll see it listed as minimum effective strain, or MESM. This is bone remodeling only occurring when bone strain exceeds the MESM value for that particular person. So When there's enough of a stimulus, then you're going to get bone remodeling to occur. Now, the interesting thing is that bone cells do have a quote-unquote memory for these kinds of loading problems, so it could modulate future responses to mechanical loading. What are the micronutrients and hormones that regulate bone remodeling? One of the first things that I want you to come away with understanding is that plasma levels or blood levels of calcium are tightly regulated. There isn't much deviation whatsoever in these levels. That's how important it is. So if we have a chronic low dietary intake of calcium, that's going to increase the release of a hormone called parathyroid hormone. And that parathyroid hormone is very, very important in making sure that calcium levels in the blood get back up to the level that is necessary. So in this diagram down here at the bottom, what you're seeing is the chronic low dietary calcium and loss of bone mass being represented here because of the release of parathyroid hormone and an effect of trying to increase plasma levels of calcium once again. So we have parathyroid hormone that is going to mobilize the osteoclast, which is going to increase bone resorption, which means that we're going to chop up that bone mineral and release it out into the bloodstream so we can raise levels of calcium. So that's one of the things that parathyroid hormone is going to do for us. So parathyroid hormone is going to cause the osteoblast to round up and expose mineral for the osteoclast. The osteoblasts are also going to stimulate the release of interleukin 6, or IL-6 for short, which is going to stimulate osteoclast activity and therefore increase bone resorption. So under these conditions, there is going to be an incomplete replacement of bone mineral content, so that's going to shift things in the direction of bone mineral density loss. We're also going to decrease the amount of phosphorus retention by the kidneys and increase calcium retention by the kidneys. So we're going to waste less calcium in urine. This is also going to stimulate the conversion of 25-hydroxy D3 to 1,25-dihydroxy D3 by the kidneys. So the thing to understand here is that 1,25-dihydroxy D3 is actually the active form of vitamin D. Vitamin D in this case is actually acting as a hormone. It's going to facilitate the increase in absorption of calcium, so it's going to promote calcium absorption. Calcitonin is another important hormone here that has the opposite effect in regulating blood calcium levels. So basically when calcium levels in the blood begin to increase above the homeostatic level, then we're going to try and reverse some of that calcium from being in blood. So we're going to promote calcium uptake by bone over the long term. And so we do this by taking the osteoclasts and rounding them up, which then allows the osteoblasts to spread out and increase bone formation. So we decrease resorption of bone and then increase bone formation. Now vitamin D helps prevent bone demineralization by mobilizing the osteoblasts and then minimizing the amount of parathyroid hormone secretion. So there is a feedback mechanism here that prevents parathyroid hormone from being constantly secreted at high levels. We know that estrogen is also preventing parathyroid hormone from activating the osteoclast via the osteoblastic stimulation of IL-6. So this is a slide that shows the pathways here that we talked about. And if we start here on the left and with the begin section here up at the top, we have levels of blood calcium that decrease, which then stimulates the parathyroid glands to release parathyroid hormone. That increases the blood levels of parathyroid hormone, and the effect on the kidney is simply going to be to decrease phosphate reabsorption, which increases the urinary excretion of phosphates and decreases plasma phosphate levels. We're also going to increase the calcium reabsorption from the kidneys by decreasing the amount that gets urinated out, which helps restore the plasma calcium levels back to normal. We also, in the kidney, activate the 1,25-dihydroxy D3, and we release that D3 out into the bloodstream, which then is going to promote an increase in calcium absorption from the gastrointestinal tract. Now, parathyroid hormone is also going to increase bone resorption, so we're going to release the mineral calcium from bone into the plasma, again in an effort to bring those calcium levels in the blood back up to normal. Now, over on the right-hand side here, we see the process of vitamin D in its early stages as far as how it's produced. And so we do get vitamin D from sunlight, and the way that happens is basically UV light converts 7-dehydrocholesterol into vitamin D3. We also obviously can get vitamin D from the diet. However, the diet is kind of a difficult place to get vitamin D from. There are very few sources of vitamin D, which is why things like milk are going to be fortified with vitamin D to try and help people meet their vitamin D needs. So this all helps increase the plasma levels of vitamin D. In the liver, we take the D3 via an enzyme here. We're going to convert that into 25-hydroxy-D3. And then, of course, in the kidneys, we take the 25-hydroxy-D3 and convert that into 125-dihydroxy-D3. Parathyroid hormones, obviously, as we discussed, going to have an effect on this conversion and activation of D3, which then releases that D3 into the blood, and then, of course, causes an increase of calcium absorption through the gastrointestinal tract. This diagram is showing you the role of IL-6 in all of this. So parathyroid hormone can have a stimulatory effect on osteoblasts, which then causes the osteoblast to round up and activate IL-6, which then causes the activation of osteoclasts, and of course then we get bone resorption and the loss of calcium from bone. Down at the bottom here, what we're seeing is the effect of estradiol or estrogen, which is going to inhibit the osteoblasts from stimulating the release of IL-6, which then means that the osteoclast won't be mobilized and the bone is going to remain intact. This is a schematic of putting all of this stuff together, so I would go ahead and take a look at it. It's pretty self-explanatory. It involves all of the aspects that we just discussed earlier. So take a look at this and try and use it to help you keep the big picture together with bone loss here related to parathyroid hormone changes in the bloodstream. How does calcium intake affect bone mineral density throughout the lifespan? So let's take a look at what happens during childhood and adolescence. Well, we're combining calcium intake with exercise during growth that can have some additive effects on bone mineral density, so that's a good thing. However, calcium consumed isn't necessarily transferred directly into the bone reservoir, so that's something to consider here in children and adolescents. Children do have the ability to increase calcium absorption and retention despite low dietary intakes. They can go as low as about 400 milligrams per day and still maintain good bone mineral density. In the adult, absorption efficiency and retention is only about 4 to 8%, whereas in children, that absorption efficiency of calcium and retention is going to be as high as 80%. So we may also be borrowing calcium from the cortical shell to meet this demand. So we're not quite sure exactly what's going on there, but that might be a possibility and the reason why children and adolescents can get away with reduced dietary intake of calcium. In order for bone mineral density to be compromised in children and adolescents, there needs to be a severe deficiency, which is seldom seen in the United States. In the most severe cases, we do see bone growth occurring, but it's happening at a slower rate, and it's normal in shape and size. It's just lower in bone mineral density or bone mineral content. Calcium supplementation may increase bone mineral density by about 1 to 3%, and the greatest responses seem to occur within the first 6 months of administration of that supplementation. When you cease the calcium supplement, then bone mineral density actually returns back to baseline. So once peak bone mass is achieved, increases in bone mineral density are primarily due to mechanical forces. So once the genetic potential has been maxed out, it's really the mechanical loading and all of those forces on the skeletal system that are going to help promote an increase in bone mineral density. Moving on to the premenopausal years here, calcium retention and absorption is going to be at its peak efficiency. And that's important because we want to stress having sufficient calcium, vitamin D in the diet during these years so we can maximize the genetic bone mineral density potential. The calcium requirements are going to be at their lowest, about 1,000 milligrams per day. Study results do vary considerably and are actually inconclusive. Bone mineral density doesn't appear to differ with calcium intakes, which is kind of interesting. However, mechanical loading and genetic factors and environmental factors may actually be more important in developing that peak bone mineral density in premenopausal women. Moving on to the perimenopausal and early postmenopausal years, around the age of 50 or so, there's conflicting data, and sometimes there's non-existent data for calcium supplements. Calcium intakes of about 1,000 milligrams per day might actually help increase bone mineral density, but not very much, about 0 to almost 2% per year. All the sites may be affected except for the vertebrae. However, bone mineral density might be more related to estrogen and progesterone levels. In the late menopausal years, a calcium supplement is associated with the maintenance of skeletal mass without any gains in bone mineral density, and this happened at about 800 milligrams per day, so that actually can help decrease bone mineral density loss. And it seems that this can slow appendicular bone loss, and the actual bone loss can also slow down in women who are postmenopausal by about 10 years in some studies. What's the mechanism behind calcium supplementation and supporting bone mineral density? Well, this is the bone remodeling transient model, and this says that we have decreased activation of new remodeling sites, which means then we're going to have a continuation of early bone formation at existing remodeling sites. There was still a deficit between calcium lost and in resorption and calcium formed, just a decreased rate of calcium loss. So losses of calcium are slowed a little bit rather than changing the bone resorption and bone formation. Practical application of this material, top of the list here as always, education. We want to educate the athletes, the coaches, etc. about the female athlete triad. Very important that everybody's on board with this and understand the health ramifications of this. We need to question athletes about their menstrual history. If they are more than 6 months amenorrheic, we need to send them right to a physician to take care of this problem and see what's going on. We want to monitor the amount of sodium, protein, caffeine, and alcohol intake because that does promote the urinary loss of calcium. So as an example here, about 2.3 grams of sodium per day can result in a urinary calcium loss of about 40 milligrams per day. So that's a pretty significant amount of calcium that may be lost. So this could put the person in a negative calcium balance. We want to increase calcium intake from food first, at least 800 milligrams per day if we can. The amenorrheic athlete actually needs about 1,500 milligrams per day to offset this through the diet. So we can use the DRI tables, the dietary reference intakes for age and gender, for some more specific recommendations, or in the literature, if we find some new information dealing with athletes, then we should probably try and follow those recommendations as well. But however, the typical ranges are around 1,000 to 1,300 milligrams per day in the literature. We need to make sure that there is, of course, adequate vitamin D intake as well. We want to avoid and discourage any kind of cigarette smoking. We want to ensure adequate calcium intake, especially during adolescence. We want to show the athlete results. Just talking about the issues is not an effective way to get the athlete to comply. So we want to build rapport and show the athlete good results. We want to ensure that the female athlete has sufficient energy intake, that they're not running these deficits, particularly over 30 kilocalories per kilogram of body mass. So this may require great effort on behalf of the athlete to consume sufficient calories. Sometimes it's not easy for athletes to get all the calories they need. They may not be doing this intentionally. We need to make sure that we're taking calcium supplements at bedtime or between meals as indicated. This decreases the likelihood of interaction with other micronutrients. We need to be careful with a high calcium intake with meals because that does inhibit iron absorption as well. Spinach is high in oxalic acid, which can make your mouth feel a little bit dry, but the more important part here is that it also combined with calcium so that less calcium will end up being absorbed. Not a huge contributor, but it can contribute. Calcium absorption is also greatest when the dose is less than 500 milligrams per dose. But unfortunately, the compliance might actually be poorer with multiple doses, so we need to figure out what works best with that particular athlete. A medical referral should be used when the athlete is greater than 6 months amenorrheic, the athlete has a history of anorexia nervosa, there have been occurrences of stress fractures, the athlete is postmenopausal, or there is a strong family history of osteoporosis. The DEXA machine, which you see pictured here in this picture, should not be used as routine screening simply because there is a exposure to radiation, so there are of course inherent risks to radiation. However, the dose is quite low, so if you do get one of these scans once every year or every couple of years, the amount of radiation you're getting basically by visiting Las Vegas and staying here for 3 days, you will get the equivalent amount of radiation that the DEXA puts out, which is kind of an interesting thing to think about. We want to encourage women of all ages to participate in weight-bearing activities of jogging, tennis, aerobics, walking, etc. Anything where we have to move our body weight with each step is encouraged here. And of course, we want women to also weight train. Again, we want to emphasize that this is not bodybuilding kind of weight training. This is just generalized weight training to promote strength in bone mineral density as well as muscles to support joints. We want to make sure where we're getting our calcium supplements from. So we can have contaminated bone meal or dolomite supplements that could contain cadmium, mercury, arsenic, or lead, which are heavy metals that can cause some health problems for us. We want to be careful of hypercalcemia, which with doses of greater than 4,000 milligrams per day, that can lead to confusion, anorexia, which is a lack of appetite, not the eating disorder here, abdominal pain, muscle pain, as well as weakness. We also run the risk of milk alkali syndrome, which puts us in the state of alkalosis, so we can change the pH of blood. We can get hypercalcemia and hypocalciuria. Calcium deposits in the kidney and other tissue are also possible, so you get calcification of tissues. You can run the risk of deficiency of iron and any other divalent cations, which results from a decreased absorption because you have competition for absorption from calcium. We also can have exacerbation of constipation with these kinds of levels of calcium. So which calcium supplements are beneficial? Well, research has looked at this, and calcium chloride doesn't seem to be absorbed very well. However, calcium carbonate is a little bit better. The absorption is slightly less than milk, and it's insoluble at a neutral pH, which is good for absorption. Calcium citrate and malate seems to be absorption similar to milk here, as well as the highest absorption fraction. So calcium citrate, malate supplements seem to be what's recommended. Some soluble calcium salts or dairy products are also good sources, but the most important thing when you're looking at supplements is also to look at the calcium percentage. Sometimes there are chelators there that make these substances more water soluble, and so if you're just looking at the overall grams or milligrams of that substance, it can be deceiving because the amount of calcium may actually be less. So you need to look at the overall calcium percentage in the supplement as well, not just the overall weight of the bottle and what's in each capsule. How can I determine the digestibility of calcium? Well, there's a simple thing that you can do with these calcium tablets, along with any other kind of supplement in pill form, and that is place the tablet in 6 ounces of vinegar, and that tablet should completely be dissolved in about 30 minutes. So if it does that, then you know you've got a higher likelihood of good absorption of that particular supplement of calcium. The last slide here shows us a list of common food items that contain calcium, and so I've listed this here for reference. So you can take a look at the amount of calcium that each of these foods are providing us. So yogurt, 1 cup of yogurt is providing 415 milligrams, so that's a really nice source of calcium.